And now it's my pleasure to introduce today's speakers. Our main presenter today is Professor Mark Lazenby. Mark is Professor of Nursing and Philosophy and Dean of the UCI, University of California, Irvine, Sue and Bill Gross School of Nursing. As an international expert on psychosocial cancer care, Dean Lazenby's research has focused on the spiritual support of cancer patients from religious minorities. He has conducted psychosocial cancer research in Botswana, Jordan, and the United States, and this has given him a broad societal and religious basis for addressing the human side of cancer. His book publications with Oxford University Press have attracted a global audience from well beyond the nursing community to consider the meaning and the importance of the profession of nursing to a good society. Prior to UCI, Mark was a professor of nursing and philosophy and associate dean for academic and student affairs at the University of Connecticut School of Nursing. And prior to this, he was at Yale University, where he was associate professor of nursing, associate professor of religion and health, and core faculty of the Whitney and Betty McMillan Center for International and Area Studies. We're also lucky today to be joined by Nicole Tullio, who recently was appointed as Director of Nursing at St Vincent's Hospital in Sydney. And Nicole has been a St Vincent's nurse for many years, most recently leading the heart-lung clinical team, clinical stream, I should say. Her role is to shape a supportive care and work environment that enables nurses to deliver compassionate care. And with a deep understanding of the St Vincent's mission and values, Nicole is working to ensure that nursing excellence thrives while research and education continue to grow. So we'll begin today's webinar with a talk by Professor Lazenby on fulfillment and meaning in healthcare and various other themes. This will be followed by a discussion and reflections with Nicole, and we'll then, time permitting, have the opportunity to take some questions from the audience. So I believe there's a Q&A box that you can click on up the top to type in your questions if you'd like a question to be put to our speakers. I think that might even just be the chat function possibly. And we'll try and just select a representative sample of questions to put to our speakers at the end of the panel discussion. So without further ado, I'm going to hand over to Mark to present. Thanks very much again, Mark, for joining us today.
Thank you, Xavier, and it's a pleasure to be in Australia, and I join you from the Brisbane campus of the ACU. So let's begin by exploring fulfillment, and I will, I think, quote a little bit of Walt Whitman's poem, The Womb Dresser, in due course, but fulfillment ranks as one of the most universally understood yet elusive concepts to define. This elusiveness notwithstanding, I invite you to explore it with me in the context of the health professions, particularly because more recently in the history of the health professions, we've become defined by burnout, moral distress and moral injury, and the unrelenting pressures of modern healthcare. So amid this ongoing definition to define us negatively, as it were, I'm seeking to ask us to think about the positive side of healthcare through this exploration into fulfillment. You may have heard of Walt Whitman, the pioneering American free verse poet of the 19th century. And some of you may know that he was also famously a nurse during the American Civil War of 1861 to 1865, which still ranks as America's bloodiest war on foreign or domestic soil. In The Wound Dresser, he describes tending soldiers as a nurse and offers a blend of compassion and unwavering resolve. And I'm going to quote a little bit here and there. An old man bending, I came among new faces, young men's faces peering amid the old, who gazed curiously on me, the veteran soldier's friend. I was familiar then with many wounded and many dying. Just as Whitman, an older figure who'd lived a lot of life when he had become a nurse, enters a crowded ward to care for the wounded he'd never seen before, we too enter our work as healthcare professionals, shaped by our past experiences, but confronted with the challenges of our present times. And often that creates a dialectic in us. And I'm going to play with this dialectic throughout the talk. So let's begin this journey into a dialectic by talking about the hidden nature of fulfillment. Why do we talk so little about it in healthcare? One reason is that even though we know what it means, like we understand the word fulfillment, it resists easy definition. It resists measurement. Unlike burnout, you can find many tools how to measure burnout. And most of these tools have core dimensions like exhaustion, mental distance, and emotional and cognitive impairment. Yet fulfillment is subtle and personal. It grows in the tension between personal reflection and collective action. This elusive quality is neither easily quantifiable nor clearly visible, yet it holds a powerful influence on how we perceive and enact our roles. Building on this idea, the contemporary philosopher Joanne Chula, in the Oxford Handbook of Meaningful Work, offers critical insights into why fulfillment is so often overlooked. She argues that the moral dimensions of work are integral to how professionals find meaning, particularly when they face systemic challenges. In healthcare, these challenges often include chronic understaffing, dwindling resources, and policy decisions made far from practice. Moreover, in healthcare, we engage in moral labor, and moral labor is not usually recognized. I call moral labor the process of balancing personal values and professional care with institutional demands. When we consider fulfillment in this light, it emerges as an active pursuit that's bound up in who we are morally. Chula's perspective also underscores how our agency, that is, our capacity to act morally within complex systems, can be constrained by external forces. And indeed, the classic definition of moral distress is when we can't do what we think is right because of institutional constraints. For example, in my profession, nursing, many nurses complain about having to adhere to protocols that prioritize efficiency over care that is attuned to the nuances of individual patients' needs. You have your own examples of such institutional constraints or the tension of moral distress. But Chula points out that meaningful work does not vanish in such scenarios. Rather, meaningful work shifts to a space of creative negotiation. As healthcare professionals, we continuously adapt to meet the needs of our patients while preserving our sense of moral integrity. This resilience in these morally complex settings is precisely what sustains fulfillment. Chula's argument is that meaning in work arises from more than just completing the functional tasks. It's interwoven into relationships, into shared values, and a commitment to the greater good amid institutional constraints. So, when we advocate for a patient's needs despite institutional barriers, or when a teammate collaborates to solve a clinical problem, we engage in moral endeavors that are fulfilling. In these moments, fulfillment becomes an act of quiet defiance against the dehumanizing aspects of healthcare. a way to assert our moral identity, even when the odds seem stacked. This hidden nature of fulfillment can be understood through the lens of meaningful work. It's not something that can easily be tabulated or on a spreadsheet or demonstrated through statistics, while burnout can. Instead, fulfillment grows in the moral soil of day-to-day practice, where compassion, reflection, and commitment to a greater good converge. Amid scarce resources and systemic inequalities that so often characterize our healthcare landscape, and this is not necessarily new, right? This has been the case. You can go back to the 70s, and people are talking about institutional constraints. Healthcare professionals still have to uphold patient dignity, support colleagues, and remain steadfast to our commitments amid these constraints. And so while fulfillment's not easily captured in the data, it remains a testament to our character and to the moral characters of our professions. Whitman's poem captures this hidden dimension. Bearing the bandages, water, and sponge, straight and swift to my wounded I go. To the long rows of cots, up and down each side I return. To each and all, one after another, I draw near. Not one do I miss. You get the sense that this hospital, probably a tent in a field, is jam-packed with a bunch of young men who've had their limbs amputated or, guts blown out. That's an image that we'll come back to in his poem. And yet he doesn't miss a one, right? This deep sense of moral commitment. And yet you get the institutional constraints to the long rows of cots up and down, right? Fulfillment in his poem here is neither declared nor measured. It simply emerges in every compassionate act. But there's a paradox in this. Being a healthcare professional is both deeply rewarding and emotionally taxing. The very qualities that make it meaningful can leave us susceptible to burnout. I have no doubt that burnout is real. I couldn't find statistics for Australia, and maybe that's because of the hegemony of the United States, or maybe it's because you all are doing better than we. I hope it's the latter. In the United States, though, 73% of social workers, 62% of nurses, 60% of paramedics, 53% of physicians, 50% of physiotherapists say they experience symptoms of burnout. So take your pick. Half, at least half, the minimum half of healthcare professionals say they experience burnout. Herein lies the paradox. The very moral and emotional engagement that's required to perform our jobs well also drain us. If aren't adequate resources, and I think recognition, and what I'm suggesting today, reframing. Fulfillment does not hinge on the absence of these challenges, though. Rather, it emerges in intentionally navigating them. In my world, cancer nursing, moral distress might come, or burnout might come, from watching a patient in the ICU whose body is very clearly shutting down from the ravages of cancer, while the oncologist continues to prescribe chemotherapy. Now, that's a classic example. I think if you've worked on an oncology unit, you've probably seen that. Right? The resulting emotional toll, while significant, is a testament to the cancer nurse's commitment to the patient, but also, I've seen this happen many a time, the nurse go to the oncologist and say, this is wrong. And so that quiet defiance against the dehumanizing aspects of healthcare takes root in these morally challenging situations. In The Wound Dresser, Whitman implicitly highlights the paradox I'm talking about. He grapples with the heartbreak of seeing so many suffer, yet he refuses to abandon his post. I onward go, I stop, with hinged knee and steady hand to dress the wounds. I'm firm with each, and the pangs are sharp yet unavoidable. One turns to me his appealing eyes. Poor boy, I never knew you, yet I think I could not refuse this moment to die for you, if that would save you. Whitman does not evade suffering, his own emotional toll. Yet it brings meaning to him. We understand what fulfillment means, even though it's elusive. It arises in moral complexities, yet it does bring purpose. After all, if healthcare were in the Garden of Eden, well, we wouldn't need it, right? And we would not experience fulfillment. Another seemingly duality is the nature of healthcare professions. All healthcare professions are scientific, but all have an art. And I'm going to intentionally call this art spiritual. On the one hand, we rely on evidence-based practice, rigorous training, and technological acumen. On the other hand, we engage with patients in profound moments of vulnerability, moments that call for compassion, moments that call for this feeling of I could lay down my life for you if it would save you. This dual nature is not simply an overlay of clinical science on humanistic concern. It's an interwoven fabric that makes our healthcare practice both effective and meaningful for us and for patients and families. Our ability to hold these two dimensions together, the scientific and the spiritual, is central to fulfillment. From a scientific standpoint, the healthcare professions demand an extensive body of knowledge and, yes, an adherence to institutional protocols. Accuracy can literally be a matter of life and death. Yet if we view patients only through a clinical lens, we risk overlooking the dimension of care that addresses the whole person. Scientific proficiency is a powerful tool, but it's incomplete without the human touch. Just as compassion and dedication can lead to burnout and moral distress, balancing science and spirituality can create its own form of strain. We often find ourselves caught between the demands of clinical efficacy and the desire to spend more time with patients. When these demands collide, that's when moral discomfort arises. Yet it's precisely in this discomfort that we discover our deeper purpose. Meaning does not vanish, but rather it emerges when confronted with constraints. Here, our agency becomes pivotal. We harness our scientific knowledge to stabilize, to cure, etc. But we acknowledge the spiritual dimension that asks us to see beyond diseases and disorders to the person living with them. At the bedside, fulfilling this dual mandate requires courage and commitment. Fulfillment in healthcare practice thrives on the synergy between these two realms, the scientific and the spiritual. A clinician who excels at interventions but neglects the human dimension risks alienation and detachment, and we've all met them. Conversely, focusing solely on emotional labor can lead to ineffective or harmful care. and we've all seen that. It's the dance between these two that allows us to experience the fullest sense of purpose. In the rhythm of heart monitors and hushed midnight vigils, in the data-driven diagnoses and the quiet prayers whispered over a patient's bed, we discover the essence of fulfillment. This integrated approach, rooted in reason, is open to humanity. Now, having argued that the scientific and the spiritual form a crucial balance in our work, I want to turn now to an idea that helps us sustain that balance. And this idea is rational compassion. Whitman's work reminds us of this balance. In The Wound Dresser, he attends to the dripping and red wounds with near clinical focus. Yet he offers gentle words that acknowledge the soldier's pain. I am faithful. I do not give out. The fractured thigh, the knee, the wound in the abdomen, these and more I dress with impassive hand. Yet deep in my breast, a fire burning, a flame. The contemporary psychologist Paul Bloom describes the concept of rational compassion in his 2016 book, Against Empathy. Now, I want to pause here and say that I think we use empathy often when we mean compassion, and I'm going to get very technical with the definitions of both. Empathy, Bloom argues, is the capacity to vicariously experience someone else's emotions. It really, for Bloom, it really does mean when you take on the same emotion that someone else is feeling. It's not merely an abstract understanding or a detached concern. It involves a kind of emotional simulation where we literally imagine what it's like or what it is to feel like the other. The term was coined in 1909, empathy, so it's a new word in the human lexicon by the British psychologist Edward Titchener. He introduced it as a translation of the German word Einfühlung, which means feeling into or projecting oneself into someone else. Interestingly, in Against Empathy, Bloom does a little history of fascism and says that fascism really flourished when the fascist says, I know exactly what you're feeling to the dispossessed. And we see that going on today in my country. Bloom says that empathy is the tendency to absorb another's feeling as one's own. And as such, if we do this in healthcare, it can be hegemonic. We take power over the patient's emotions, and it can lead to our own burnout. Compassion, on the other hand, Bloom writes, recognizes someone else's emotions without taking them on. It's a recognition without feeling the same as. But it is always coupled with a strong desire to alleviate suffering. And along these lines, I recommend to you Margaret Farley's little book, Compassionate Respect, published by Paula's Press sometime, I think, in the late 90s, early 2000s. Very similar idea. And Paul Bloom and Margaret Farley were on faculty together for a very long time. They've influenced each other. So according to Bloom in Against Empathy, the solution is not to take on another's emotions, but to balance our recognition of their emotions with a measure of logical reasoning about how we can alleviate their suffering. By so doing, we address suffering effectively while maintaining our emotional stability. the balance of head and heart, aligns with the scientific and the spiritual. The tension between these dimensions mirrors the tension in the paradox of fulfillment. Too little emotion and one risks withdrawal and hardness. Too much, one risks emotional collapse. Rational compassion treads a middle path. It dovetails with the popular idea of self-care. When we practice self-care, we acknowledge suffering, our own and others, which provides an internal bulwark against a cumulative toll of providing healthcare. When we rationally are compassionate to ourselves, I see my wife doing this with our son all the time, putting his emotions in context, right? This is a normal thing to feel. When we're rationally compassionate with ourselves, we make a choice to acknowledge our own humanity. In this light, fulfillment becomes less about removing our distress, and more about navigating it with intention. We harness our moral integrity to advocate for patience. We guard against the pitfalls of emotional depletion by calibrating our own responses. This calibration does not diminish compassion. Rather, it enriches it with clarity needed to make morally grounded decisions. Rational compassion supports the scientific and spiritual nature of being a healthcare professional by offering a framework in which our moral labor is both sustainable and purposeful. With rational compassion as a foundation for balanced caregiving, we also look to another practice that sustains our sense of fulfillment. And I'm going to bring it back to rational compassion in a moment. But this other practice is awe. My emphasis on rational compassion does more than safeguard us from emotional depletion. It creates the emotional and mental space for us to become attuned to the often overlooked wonders of our practice. This transition from a deliberate, sustainable practice to moments of awe reflects a broader shift in how I'm arguing we should perceive the distinction between fulfillment and burnout. Fulfillment is not about grand accomplishments. Fulfillment emerges from an awakened recognition of the awesomeness of our everyday work. In her 2023 book, Enchantment, Awaking Wonder in an Anxious Age, Catherine May argues that our deepest moments of fulfillment arise from finding significance in life's small, seemingly mundane experiences. For us, this could mean appreciating the warmth in a patient's thank you, recognizing the subtle resilience in a post-operative smile, or simply pausing to notice the gentle rhythm of a bedside vigil. Just as rational compassion allows us to care effectively without being overwhelmed, May's focus on awe encourages us to see beyond the grind of clinical tasks and notice the awesomeness of the daily routine. These small acts of attunement, a colleague's reassuring touch, or a genuine moment of laughter together in the break room, can serve as anchors of fulfillment, grounding us in the knowledge that our work is both purposeful, clinical, yet profoundly human, spiritual. Building on May's perspective of awe in the enchantments of the everyday, contemporary psychologist Dacher Keltner, who wrote a book, I think in 21 or 22, on awe, explores awe as a psychological transformational experience, one that connects us to something greater than ourselves. And this is where awe and rational compassion come together. Rather than succumbing to an emotion that leaves us drained, we can cultivate a sense of awe that inspires and rejuvenates. Then, through rational compassion, we stand on steady ground, prepared both to acknowledge the profound weight of suffering and to celebrate the glimpses of the everyday. Crucially, the practice of tuning into awe does not isolate us from the reality of suffering. Rather, it helps us carry our moral labor with intention. Just as rational compassion keeps our emotional response sustainable, rediscovering awe ensures that we do not grow numb or cynical. We have our individual and awe-inspiring experiences, all of us do. We have our own stories. But these stories, when shared, show us that we're all committed to a greater good. And in this way, the awesomeness of the everyday becomes an enduring source of fulfillment. Even during the carnage of the American Civil War, Whitman experienced awe at the dignity he saw in wounded soldiers. Thus, in silence, in dreams, projections, returning, resuming, I thread my way through the hospitals. The hurt and wounded I pacify with soothing hand. I sit by the restless all the dark night. Some are so young, some suffer so much. I recall the experience, sweet and sad. I began this talk by considering how fulfillment can be universally understood but stubbornly elusive to define. Now, in closing, I ask that we recognize this elusive quality as its most vibrant, that it finds its most vibrant expression in the day-to-day realities of our work. Our invitation then is to see fulfillment as a guiding principle, supplanting the guiding principle du jour of burnout, one that can help shape our moral decisions, inspire innovative solutions to systemic challenges, and sustain us through the inevitable hardships that come with providing care. And I'm going to pause for just a moment and give you a very practical example. Sue Kinnick in the 1990s was a nurse informatician in the state of Kansas in the United States at a Veterans Administration hospital. They were having a rash of medication administration errors. And I've actually interviewed her about this, and she's also written about it. She had to solve this problem because patients were dying and nurses' jobs, they were losing their jobs and their careers were being ruined by these medication administration errors. A real moral dilemma. And one day, she was watching a cashier at the grocery store swipe a barcode over an optical scanner. She said that was awesome. That was her word. And she knew she could take that very mundane example or experience and translate it into a solution to medication administration errors. And there's not a nurse anywhere in the world that now doesn't use barcoding to make sure you've got the right patient and the right medication. By acknowledging that the moral and the spiritual dimensions, concern for healthcare professionals, concern, deep moral concern for patients, but getting the scientific right. This is central to who we are as healthcare professionals. And in so doing, insofar as it is central, we anchor ourselves in a practice that transcends mere function. We transform daily routines into fulfilling acts. If we listen closely, Whitman's poem still speaks to us in that final stanza I just quoted. It concludes not with triumph or despair, but with a quiet acceptance. I recall the experience, sweet and sad. Its profoundly modern sensibility, an acknowledgement of both the burden and the awesomeness of caring, and that is rational compassion. So fulfillment lies not in escaping hardship, but in choosing rationally to meet it with moral courage and an open heart. Thank you.
Thanks very much, Mark, for that very powerful and poignant talk. And I mean, there's several gems that I've written down in my notes just to go back and reflect on in the coming days. And I mean, one quote I liked in particular was that meaning does not vanish, rather it emerges when confronted with constraints. And I think that frames a bit your argument for the talk, that rather than escaping when these kind of very difficult circumstances arise in healthcare, or even just the sort of day-to-day monotony of health practice may weigh you down. Like, you need to try and rather reframe with rational compassion and awe, as well as trying to balance the scientific with the human and yeah, kind of compassionate sides of healthcare delivery. So I thought that was fantastic. So I'm going to now invite Nicole just to offer a few reflections. I've got some questions here as well, so we could start with those questions, Nick, or also feel free just to offer some general thoughts on the talk and how that's landing with your own professional experience and reflections on moral distress, burnout, fulfillment in nursing. I mean, I know that you've been at St Vincent's for 25 years and during some complex times, including COVID. So just wondering perhaps how this idea of fulfillment resonates with your experience.
Thanks so much, Xavier, and thank you, Mark. Gosh, where to start? So thought-provoking, and I guess I'm looking at fulfillment as, you know, filling one's cup, and I've certainly felt that for the 25 years that I've worked at St Vincent's. I was only talking to Xavier last week or the week before about how despite the challenges, the difficult times, I don't think I've ever got up and thought, I don't want to go to work today. So it's a pretty amazing place, but I guess that's because there's an investment in the culture, and when it hasn't been great, I think there has been a focus on a turnaround of ensuring that we've got a shared purpose, and I think having a shared purpose is really fundamental to fulfillment. The connection, the collaboration, the camaraderie amongst the team, and that ability to grow together, that growth mindset, building resilience, but sharing also all, you know, the times that you talked about, you know, laughter, tears, lessons learned. I think you did refer to it earlier, Mark, just in terms of the Australian experience, and particularly when you look at the COVID, our COVID experience, it was very different to the rest of the world in the sense that we were very protected. We were immunised by the time it got here. We were able to network with our colleagues internationally about, you know, processes and the way that we could really prepare and protect ourselves. And I spoke to a lot of people around that time, and there was almost a survivor guilt in some sense. You know, our colleagues in the UK, for example, were watching their peers, their colleagues die in the ICU, and we certainly didn't experience that. But I guess what was hard for us was waiting for what was to come and not knowing what was to come. But despite that, I think, you know, the shortfalls and the stresses on nursing have certainly not turned out to how we expected. We're really experiencing great recruitment and retention in the workplace at the moment, which is probably surprising, and it just shows the resilience and the agility and the flexibility of nurses just getting on with it. It does weigh heavily on me though, the fact that fulfillment is such a personal thing and the ability to transfer that to others is not possible. So how do you do that? How do you protect against the institutional constraints in a job like mine, so that people at the front line are protected, but that they can grow and fulfill their cup in their own way?
Yeah, there's several things I want to respond to. One is the retention problem, and I think it's very similar in the United States. Some hospitals have an average retention of less, of a few years, and new nurses aren't staying. They're moving on. Let's come back to that. But to your last question on, fulfillment is deeply personal, though I think I'm arguing that we can create the conditions necessary for it. And this idea of fulfillment as defiance against the moral constraints, or the institutional constraints, I want to say that the moral conditions of work matter, right? And often they are the immoral conditions of work, right? They matter, but saying so does fulfillment is to say that there is a call here to change the moral conditions of work. And Sue Kinnick's example of inventing barcoding it's not really inventing, I mean, it's innovating, right? Is one classic example. So how do we turn the negative around and see what can be done? And of course, it also requires government investment. It's very interesting. I heard your PM. I hope he's not listening in, because in my world now, I'm totally frightened of people listening in. Say that Australians need 2,000 more GPs and so many more nurses. It was and I thought, he's not talking about the upstream problems, right? Of really sick patients, of the social determinants of health not being addressed. And they get to they get to us, and too late. There's nothing we can really do. So I think it's time for our profession, nursing, to start standing up and saying, this is the case. I think nurses have and should run for political office. I think we need to be out there calling the immoral conditions out. And yet that's a very fulfilling thing to do. There have been a few nurses in Congress in the United States, but out of 450 members of Congress, there are only 3. And of course, I don't want to run for political office, but we need more nurses and more physicians and more healthcare professionals going in and changing policy. And I think that would be fulfilling, right? At the very practical level in the hospital, I've often wondered, what if we started handoff, not with the problems, because that's how we start handoff. Patient and one, he complained all night, he didn't sleep, whatever, tacky all night. What if we start with a practice of gratitude? I'm thankful for this or that. And Robert Eamon's work, another psychologist, is showing that a practice of gratitude changes who we are. Or Dacher Keltner's work, and Keltner's at Berkeley, and he's done a lot of randomized trials that if people will pay attention to awe, moments of awe, versus the control group that are instructed not to be out in nature or not to look up at the starry sky or anything that might engender awe. The people who cultivate awe actually are pro-social, meaning when they're in the experiment, then they stumble upon somebody who needs help, they're more apt to help. What if we had practices of awe? What
Yeah.
if we talked about rational compassion? You know, that's one thing that burns us out. We get so caught up in families' dramas. We take it on. What if we really educated ourselves about this idea of don't take on the emotion, but attend to the suffering?
Mm. Yeah, so many points in that, Mark. I'm reminded by an Australian journalist and author, Julia Baird, who has written a book about awe, and she considers herself an awe hunter.
Yeah.
So I think certainly there are some really great moments, as you said, in handoff or handover, what we call it here, to stop and reflect. And we're certainly looking at ways to integrate that into our daily management systems. Looking at the restorative just learning culture and how we can include that approach to staff wellbeing. The international nurses theme this year is about caring for nurses. If we don't care for ourselves, we can't care for others. So there are so many opportunities. I think it's as you said though earlier, also being brave, being courageous, questioning authority and meaning and purpose, and turning the transactional into the compassionate care and the irrational compassion, the rational compassion. Yeah.
I do worry about the retention problem, and I don't really have a full grasp of it. And, new nurse mentorship, or what we call the United States New Nurse Residency programs, where they are mentored over 6 months, these seem to have some traction. I also think, though, that one thing we're losing in the profession, and I think this is true also in medicine because they're increasingly having a retention problem, is this sort of a way to talk about ourselves as more than just a job, as more than just a profession, right? The greater good that I was talking about. That there's not been a society for time immemorial in which there hasn't been somebody in that society who's played the role of the nurse, right? We are essential to a good society. You can't, somebody's got to do it, right? And I don't think we're talking about ourselves that way. And saying, and yeah, 18-year-olds come into the university thinking they want to do nursing without any clue of what it is. But it's because nursing is a good job. They're going for a good job. No, you're actually going for something that's far greater than a good job. And I wish we could change the discourse about the healthcare professions in general this way.
I had a question for Nick just now that we're a lull in the conversation, just kind of like a little bit lighter, but maybe Nick, if do you have a favorite story or some stories that remind you of when you've experienced fulfillment in your work? Were there any stories that popped to mind when Mark was presenting that reflected some of what he suggested would be good ways in a way to find fulfillment and address moral distress in nursing?
Thanks, Xavier. I think for me, if my team's happy, I'm happy and I'm fulfilled. And that's that connection, that camaraderie, that collaboration with teams where they do feel empowered to innovate and care for patients in a way that is deeply personal, but also, rational is amazing. That's essentially what brings me to work each day. But I think, there are those moments in time where, as a new grad nurse, just sitting with someone in ICU and being able to give them a foot massage, that allowing that time to be able to do that just in a reflective way was amazing. Calling people on the transplant list to say, we've got you a new heart, deeply, deeply fulfilling. And, years later, 8 years later, those same patients saying, I remember the night you called me. but it also transcends, I think, into, you know, your personal life. Being a nurse is, you know, constantly getting the call from mum to tell me that the uncle of someone has some issue. But, you know, I've been very fortunate in my own personal life to take my nursing into the personal space with my father, who passed away, and more recently my auntie. And being the nurse in the family, being able to reassure them, care for them, as well as, you know, my dad or my auntie along the way, has been deeply fulfilling. So I think it's certainly in the professional space, but also transcends into, you know, just day-to-day living. And I think that probably goes to your point, Mark, about the profession. And
Yeah, I totally agree. And nursing is a personal identity, right? I'm a nurse, and I don't know if I was with some friends at a conference, and somebody came up to us and said, "I'm a former nurse," and we all looked at it like, "What? Once a nurse, always a nurse, right?" It's just it becomes who you are. Um, you may not be practicing as a nurse, but hopefully that identity is there, and that's kind of what I was going into. What does that identity mean, not just for nurses, but for anybody who lays hands on the sick or who tries to keep the well healthy? That's a very profound thing, and let's capture it in its positive aspect. I mean, it really I think before COVID even the frame of the discussion was around burnout and compassion fatigue. Um, can we change the discourse, and in that maybe start to change the moral conditions? Because if we keep just talking about the negative, the moral conditions will, I think, remain the same.
Mark, I'm interested in that. I could certainly have hope and can see so many opportunities in that space. What do we do about the people who have moral injury? So the ones that are actually, you know, how do we repair and heal that trauma, that trigger?
Yeah. Yeah, no, I mean, moral injury, that, you know, the senses of the feelings of shame and guilt and deep despair. You know, how do we heal it? I that's kind of out of my space. Like I haven't researched that, but you know, I go to several things. One is again the current psychological work on awe and gratitude. They're very healing. I also I've been very interested in this other aspect of an intervention for insomnia. So the intervention for insomnia is cognitive behavioral therapy.
Yeah.
And one proven mechanism in it is setting aside time to worry. And if we don't set aside time to worry, where we're just doing nothing else but worrying, we're going to wake up in the middle of the night worrying, or we're not going to fall asleep because we're worrying. And the theory is that the brain can't worry when it's doing other things. And I really think that we need to set up these intentional practices in which we name our anxieties, we name our fears, we bring out those past experiences that trigger us, and nothing else. Right? We're just getting them out. Right? And I've been calling this prayerful worrying, like and one can do it. I call it mindful worrying. You can call it whatever, but for me, it's like why I call it prayerful worrying is that C.S. Lewis says prayer is not to change the mind of God. You know, who are we to think that we can change the mind of God? It's to change us. So what if this kind of very basic CBT intervention of naming our fears and moral injury is very, very much, you know, I'm not going to do this again. It's very deeply anxiety based and fear based. Let's name it. And then of course, you know, I have my own examples, and I'm sure any nurse has their own examples of a practice situation I'll never go back into, right? I know that I won't be in that situation again because it's unsafe. And acknowledging that that's a protective mechanism. I don't know if I answered your question.
No, I think you did. Yeah.
Oh.
That's
Thank
great. So I thought at this juncture, perhaps we could take a few questions from the audience, and I've got one question here that's been popped in the Q&A chat, which I could start with, and I'd encourage audience members to, if you have questions, just to pop them in the chat there. So Esther Adams is asking, I wonder if there is an opportunity in the way we deal with complaints and mistakes that could help foster fulfillment. So interesting question.
I totally agree, Esther. There's got to be a better way. And we've talked about just culture. Nicole, you've called it, what do you call it here?
Restorative just culture, restorative just learning culture. And that absolutely is where we're hoping to make the difference, to look at what happened, what was the mistake, what was the incident, who did we cause harm to? And most often it is the nurse. And how do we rectify that? How do we help them through it?
And I think with that, Esther, it's that the institution has so often not taken responsibility, right? It's very much been about figuring out what people did wrong. But I want us to use these moments of asking not just what went wrong and who did what, but what were the institutional, what the setting, right? What was going on in the institution that sort of led to it, and I think in almost every instance we'll find some institutional constraint that set the conditions that were necessary but not sufficient for the act, and so switching to think that there are many actors, a corporate actor, and then individuals. Is a way to lessen the negative frame. And then the second thing I'm really curious about, not all institutions do this, is say this is what we've learned as an institution, right? This is how we're changing. And if you've been involved in an error, or you've had to make a complaint, it's nice to know that something good came of it, right? And that's this commitment to the greater good I've been talking about. I don't think you can have fulfillment without a commitment to the greater good. Esther, I hope that answered your question.
Thanks very much, Mark. And I've just got a question that's come in from Callista Castles. So thanks for your presentation, Mark. What I hear in your talk is not just broad fulfillment, but value fulfillment. In Australia, many nurses and healthcare professionals work in value-based organisations, usually charitable organisations, often Christian organisations. Resource constraints have contributed to value violation, or as you mentioned, moral injury and moral distress. Is there a more central place for values to help guide practice and organisational transformation towards fulfillment conditions?
Yes, there is. And I think they can be institutional, but they need to be professional too. And this is, if I were giving this to just a nursing audience, I would argue that nursing has a moral character as a profession. I think medicine does too. I think almost any healthcare professional does. And we've got to start bringing those values out even more. For example, I notice in our physical assessment or our health assessment courses, both for our registered nursing students and our nurse practitioner students. So we teach a lot of nurse practitioners at my university because we're primarily a postgraduate institution. And we teach them how to auscultate, right? And it's just become very kind of mechanistic of, you listen to the aortic here, you listen to tricuspid here, Erb's point, etc. And I'm like, no, but you're laying hands on a person, right? This is an act of laying hands on someone. And what does that mean? What is that act? And it's long been talked about in nursing, laying hands on the sick, um, and caring for the potentially sick to keep them well. My favorite definition of nursing is doing for a person in public what they would only do for themselves in private, right? That's a huge value, right? You are in that the humanity that's there, the intimacy that's there, the privilege that's there. Let's start talking about those again. And yeah, I don't think you can have fulfillment without that component.
Great, thanks very much. Just a question from Glenn Babachi. So hi, I'm sorry, I'm not a nurse, but a peer worker in the AOD at St. Vincent, Sydney. And the most recent teaching in helping people with drug use is called strength-based rather than hitting rock bottom. So someone asking for help or coming in for an appointment can be a big strength. My question is how to keep that sense of fulfillment when actual success is a very low rate. For example, AOD is as low as 1%. That is an estimation from experience.
Yeah. Yeah. No, that's right, Glenn. And you're working in a very difficult area of practice. It's sometimes as a cancer nurse, and I really worked mostly with people at the end of life. I sometimes fantasized about working in an area where everything was rosy, and then I started talking to the midwives and realized, oh, you know, there are postpartum hemorrhages that lead to death. There are stillborns. There are, it's all around us. But I don't think any has quite the low rate that you quote there. That's surely very difficult. Um, uh, I think I go back to Walt Whitman here for a moment. Just imagine being a nurse in the American Civil War, where I think most of the people died and was just bloody, and the only thing they really had to do was saw off the limb. You certainly the wound in the abdomen that he attended to, that person was going to die, right? Um, uh, COVID was another example for those of us who did sort of medical care. I think it comes down to your sense of commitment to the greater good. And I think it does come down also to recognizing your own limits. Um, it doesn't mean you have to be a peer worker in that arena all the time. I think some people have inner strength to do it all the time, and some people's inner strength is in a different area or has a time limit. And just, I was an oncology nurse practitioner for 15 years, and now I'm an academic, right? So we all have these phases of what we can do. And I'm stumbling around, Glenn, because I'm impressed at what you do. Substance use disorder, as we call it in the United States, is super challenging and increasingly prevalent. And and I want to say carry on for as long as you can carry on. I I wish you could speak to me. I wish we could speak, Glenn, because this is a go to the pub kind of conversation.
Hopefully we can have our next conversation in a nice pub here in Sydney, perhaps, Mark. But just maybe a final question here from Jackie Bilo. I think there are many moments of fulfillment in healthcare, and it's incumbent on us as leaders to recognize, celebrate, and create opportunities to share those moments. How can we encourage this? So how, as leaders in the health sector, can we encourage and share those moments when we find fulfillment?
It's not hand off a report. What's it called here?
Handover.
Handover. Let's do it in handover. Let's name one thing that we found fulfilling, one act, one moment that really we felt good about in the shift as nurses. The dean of medicine at my university and I are good friends, and he's asking, he's a colorectal surgeon, so that's where he has the greatest influence. He's asking the colorectal surgeons to do that, right? Just name one thing, even post-surgery, just one thing that you felt good about in that moment. And this really, it's coming out of the psychology departments. You know, if we talk about awe, if we talk about gratitude, if we do name our worries and our anxieties, we're going to actually feel better. And I think we need to start integrating these into our practices as healthcare professionals, regardless of our stripe. And Glenn, I guess this is one of my answers to you. And then we need to look at it as ethicists, as a moral thing to do. It's a good thing to do in the moral sense, right? It reframes us.
So we've just got a question from Dan Fleming, who assisted organising this event. So I think we should make sure that we get it in. So just a reflection and brief question. So Mark, I love this concept that fulfilment emerges when encountering the limitations, but purposefully finding a way through. It reminds me of the founders of so many of the organisations represented here today, often sisters who were also nurses who encountered great limitations and yet kept moving forward, building the foundations for what we now continue. The constraints they faced were never paralysing, just the conditions in which the next step could be taken. Would love your thoughts on the place of legacy, nursing and organisational, in finding fulfilment.
So at Yale Divinity School, Margaret Farley, she was a professor of systematic theology there for many, many years, and she was a Sister of Mercy. She's probably most famously known for her 2005 book, Just Love, which the Pope got her, the then Pope silenced her over. Margaret wasn't a nurse, but she was a spiritual director for me for many years. And her mantra, Daniel, was just get on with it. That somehow the values of the Sisters of Mercy, I think, is like, just keep going. And of course, her little book, Compassionate Respect, is full of even hint, and she wrote that at the height of the AIDS crisis, full of awareness of what we need to do as clinicians to take care of ourselves. So these values, I think, are the legacy of religious institutions and other institutions that have created hospitals, whole approaches to healthcare. Yes, they are very much a part of it. And I am arguing in nursing that we need to reclaim this sense of our legacy, of the art of nursing, that, as we call it, I'm calling it the spiritual side of nursing intentionally, that's a legacy that's old. It's as old as the modern profession, and we need to own it.
I've got a hand from Dan Fleming. So Dan, did you want to just comment on that? We can let him. Just saying thank you. Okay, thank you.
And I see a comment from Laura McIntyre. I will send Xavier a bibliography of all the books I've spoken about.
That's terrific. Okay, Nicole, did you have any kind of final comments you wanted to make before we close here?
No, just big thanks to you, Mark, and lots of things to think about and opportunities to innovate in this space and look after the people who care for our communities. So thank you.
You're welcome. Thank you for having me.
So a huge thank you on behalf of the Plunkett Centre and the Faculty of Health Sciences at ACU, as well as the Symons Health Australia Network, to our two guests, Mark and Nick, for joining us today. You've been tremendously insightful. And I think that you've really, I think, given this topic a good working overlap. We've been able to say a lot, cover a lot of ground. And I think given that often these discussions can sometimes remain a little bit abstract. This has been a uniquely practical session as well, and I think humane and insightful. So in that way, so just very grateful to both of you for your insights. And so we will have another Plunkett Centre webinar in the next quarter of this year. So stay tuned for details of that. We're just confirming the topic and speakers in the coming weeks, but we're really grateful to everyone who's attended, and we're thrilled to see the level of interest in this event. We had 130 RSVPs, and certainly a lot of people interested in viewing the recording, even if they couldn't make it today. And thank you to everyone who asked questions as well. That was a good range of questions and allowed us to, I think, explore how this topic applies at all levels of health organisations. So really helpful. So without further ado, this brings this webinar to a close. Thanks again to everyone for joining us, and we look forward to seeing you again at future Plunkett Centre events. Thanks again, Mark.